Welcome to the OBR Perspectives Interactive Case Study Series. In this case study, Dr. Marwan Fakih discusses the advanced colorectal cancer in a 59-year-old male. Patient's characteristics included
So our patient is a 59-year-old male who presented with symptoms related to a primary tumor in the rectum. A biopsy showed a poorly differentiated adenocarcinoma. Clinically, this was staged as a T3 tumor, nodal negative, and the diagnosis was made in November of 2016. Genomic evaluation was limited at that time to RAS mutational analysis and BRAF mutational analysis and PD-L1 testing and MSI instability testing. And as you can see, this tumor was RAS wild type, BRAF wild type, PD-L1 negative, mismatch repair proficient.
Patient's treatment history included
The patient had a low-lying tumor, was treated with capecitabine plus radiation therapy between November and January of 2017. He had an excellent clinical response. He was treated in a different facility at that time and had opted, given the complete clinical response, to proceed with watchful waiting and no further treatment. Unfortunately, 6 months later, the patient was noted to have local recurrence, and restaging at that point showed that he had distant lymph node involvement with supraclavicular lymph node metastasis. This was biopsy proven. He was treated at that time with FOLFOX and bevacizumab, which was started in July of 2017 and continued for 4 months through November 2017 with a good response, but with grade 3 neuropathy. Which led to discontinuation of systemic therapy. And given the limited disease to the supraclavicular lymph node, received consolidation radiation treatment to the supraclavicular lymph node area. He was followed by observation at that point, and was noted in April of 2018 to have an increase in his CEA. And also to have further progression of disease radiographically with now evidence of metastatic disease to the liver. Again, this was biopsied, proven to be metastatic colorectal cancer. He was treated with FOLFIRI plus panitumumab starting in May 2018, received 3 months of treatment with some interruptions, and completed therapy in August of 2018. He had some mild response to therapy and underwent radiofrequency ablation to his metastatic disease to the liver, which was done end of August of 2018. Unfortunately, shortly after, he developed some obstructive symptoms and was taken to surgery, and exploratory laparotomy showed that this gentleman at that point developed peritoneal carcinomatosis. This was limited, and there was also evidence of significant progression at the site of his primary tumor in the pelvis. A palliative diverting ileostomy was undertaken, and at that point, the patient came to us for an opinion regarding possible clinical trials, given the rapid progression after FOLFIRI panitumumab, which suggests at least some resistance to that therapy, and given his ongoing grade 3 neuropathy, which was limiting for possible oxaliplatin rechallenge. So when I saw this patient, we ordered a liquid biopsy on him. We did circulating tumor DNA assay through Guardant 360. And here are the results. Interestingly and surprisingly to us, this patient had 2 alterations in HER2. As you can see, there's evidence of a HER2 mutation, HER2 S310F. And also, if you look at the HER2 amplification, the plasma copy number here is 8.1, 3 plus. This Guardant 360 assay was done before Guardant started correcting for their copy number alterations, meaning this copy number of 8.1 is actually synonymous to a very, very high level of amplification of the HER2 gene. Note that there was no RAS alterations noted or BRAF alterations noted consistent with his tumor NGS. Now, it is very seldom that you will see a concurrent HER2 mutation and a HER2 amplification. Indeed, when we looked at this data in patients with colorectal cancer in a very, very large database from Foundation One, you can see that only 1 in 200 patients with rectal cancer will have an amplification as well as a mutation at the same time. So 0.5% of rectal tumors and approximately 0.4% of colon tumors will have a concurrent HER2 mutation as well as amplification. So at that point, we treated this patient with Trastuzumab and Lapatinib. And the patient had a very, very robust improvement in his symptomatology. His abdominal pain, which was related to carcinomatosis, resolved. He gained 10 pounds. His performance status was an ECOG 2 when we started therapy. He reverted to an ECOG of 0. He received 13 cycles of treatment, and each cycle is a 3-week cycle. And eventually, unfortunately, progressed in August 2019. He had no measurable disease during follow-up until August 2019 when he developed new liver metastases. And you can see from this graph a very robust improvement in CA19-9 levels, which started at somewhere 1100 and completely normalized to about 20 to 30 during the course of his treatment with Trastuzumab plus Lapatinib. Following progression on Lapatinib plus Trastuzumab, the patient received further treatment with FOLFIRI-bevacizumab with progressive disease and FOLFOX plus bevacizumab, again with progressive disease. At that point, his neuropathy had improved. And we repeated a liver biopsy again on his progressing tumors. And we found that there is a maintained HER2 overexpression with an IHC of 3+ and maintained HER2 amplification. And we treated that patient with Trastuzumab deruxtecan from June 2020 through October 2020. And he had a brief radiographic response in his hepatic metastases, but unfortunately, after approximately 3.5 months of therapy or 3 to 4 months of therapy, he developed some progressive disease. And this is also reflected in his tumor markers here, where we started with a CA19-9 of 100 and went down all the way to approximately 50, only to go up again to about 160 in October of 2020.
Post-treatment considerations were as follows.
The Mountaineer trial looked at Tucatinib plus Trastuzumab and reported a response rate of 52% in these patients with a progression-free survival of 8.1 months and an overall survival of 18.7 months. The Hercules trial was the first study to report a benefit with HER2 targeting in patients with HER2 amplified colorectal cancer, with Trastuzumab plus Lapatinib showing a response rate of 30%, a median progression-free survival of 21 weeks, and an overall survival of 46 weeks. And this study showed a relevance to the degree of HER2 amplification and response. So if the FISH, for example, showed a HER2 amplification of a FISH number of 10 or above, or had a much better response and outcome than those with lesser amplifications. And then finally, we have the MyPathway trial, Trastuzumab pertuzumab, was evaluated in HER2 amplified colorectal cancer. Again, response rate 32%, median PFS about 3 months. But when you look at the KRAS wild type population, the median PFS is 5.3 months because the KRAS mutated did not really respond and really brought the overall population median down. And the overall survival for the KRAS wild type HER2 amplified patients receiving Trastuzumab pertuzumab was 14.5 months. Minimal to no activity was noted in the RAS mutated population. So in our patient, we elected to use a TKI inhibitor plus Trastuzumab because of the HER2 mutation and the HER2 amplification at the same time. Although the specific mutation that our patient has is an extracellular domain mutation, and really that mutation helps in the heterodimerization of HER2 and dimerization of HER2 and could be even susceptible to Trastuzumab monotherapy. So it's not really an intracellular HER2 mutation. It's an extracellular HER2 mutation, which is unique. We don't know now at this point if the other HER2 mutations that are activating HER2 mutations that are intracellular would respond to HER2 targeting. Matter of fact, in PDX models and preclinically, they tend to be somewhat more resistant. How do we manage HER2 amplification in the setting of metastatic colorectal cancer, and why did we choose these treatments? So when we look at patients with colorectal cancer, and in a very, very large database of patients undergoing next-generation sequencing of 8,887 patients, we find that HER2 and HER3 alterations occur in about 6.4% of patients. And the majority of those are HER2 alterations. As you can see, 4.8% of patients with colorectal cancer will have a HER2 alteration, and about 60% of those HER2 alterations are amplifications, and the rest are HER2 mutations. And there's a small overlap between these two, as I alluded to earlier. For HER2 amplifications, these correspond to approximately 2 to 3% of all colorectal cancers. These predominantly are left-sided, so you'll see them mostly in the rectum or sigmoid colon, but they can still be right-sided, but less often. And they do respond to dual HER2 targeting, but they respond to dual HER2 targeting only in the setting of RAS wild type status. So RAS mutations appear to decrease the likelihood of response to HER2 targeting. And there are several studies that have looked at dual HER2 targeting in patients with colorectal cancer with HER2 amplifications. And these are summarized on this slide. And the reason why we went in a second line setting or a second line HER2 targeting management with an antibody drug conjugate with in HER2, which is Trastuzumab deruxtecan here, is that that specific agent has a different mechanism of action. In HER2 or Trastuzumab deruxtecan is Trastuzumab conjugated to a tetrapeptide-based cleavable linker, which is linked to a topoisomerase 1 inhibitor. And basically, each Trastuzumab molecule is connected to 8 molecules or 8 topoisomerase inhibitor molecules. It has a short half-life. It is specific to HER2 and therefore binds to HER2 overexpressing cancer cells. And upon binding to the HER2 overexpressing cancer cells, it releases the topoisomerase inhibitor, which can have an effect either on the cell where the molecule where Trastuzumab has bounded, or even to surrounding cells by releasing topoisomerase 1 inhibitors. So let's take a look at the data with Trastuzumab deruxtecan. This is the data from the Destiny CRC01 trial, which was presented this year. And this study looked at 53 patients with metastatic colorectal cancer with HER2 amplification. And you can see that in those 53 patients, the median time to progression was 6.9 months. This is quite impressive in a highly refractory patient population with an overall survival that was not reached at the time of the study presentation. And if we look at the response rate in these 53 patients, it was quite robust at 45.3%. These responses were seen in the IHC 3+ population. Note that the IHC 2+ population did not derive a very good response here. If we look at the impact of prior HER2 targeting in this study, there were 16 patients who had received prior HER2 targeting, and nonetheless, they had the same response rates as those who did not receive prior HER2 targeting, which suggests that this mechanism of drug delivery, of chemotherapy delivery to the tumor via HER2 targeting may overcome mechanisms of resistance to HER2, specifically resistance to Trastuzumab or TKI inhibitors.
Case study summary is as follows.
In conclusion, I hope I have shown that through this case that there is value to HER2 targeting in patients with HER2 overexpressing metastatic colorectal cancer. We have 3 phase 2 clinical trials that support the use of dual HER2 targeting in metastatic colorectal cancer with HER2 overexpression with KRAS wild type and RAS wild type status, BRAF wild type status. The data is supported by Trastuzumab pertuzumab through my pathway, and Trastuzumab plus a HER2 targeting tyrosine kinase inhibitor through the Mountaineer trial and the Heracles trial. Destiny trial clearly shows that there's a role for antibody drug conjugates in this setting, specifically for Trastuzumab deruxtecan, where you can see response rates neighboring 50% in these patients. And these advantages are seen both in HER2 naive patients as well as in patients who have received prior HER2 targeted therapy. I would hope that this case highlights the need for HER2 assessment in every single patient with metastatic colorectal cancer, specifically in those with KRAS wild type, BRAF wild type status, as those are the patients who would benefit from HER2 targeting. So thank you very much.